Welcome to Section 4 in Gastrointestinal Anatomy. In this section, we will discuss the layers of the gut wall. So let's get started. Here's an image revealing the layers of the gut wall. This top layer is the mucosa. And the mucosa has three parts. The epithelium, which you can see right here. The lamina propria, which you can see labeled here, which depicts this area. And finally, the muscularis mucosae, which is this region. Now, deep to the mucosa is the submucosa. Within the submucosa is the submucosal plexus, or submucosal ganglion cells. This is also called the Meissner's plexus. And deep to the submucosa is the muscularis propria, right here. And this is composed of two layers, the inner circular layer and the outer longitudinal layer. And between the two, we have the myenteric plexus, also called Auerbach's plexus. And lastly, the most superficial portion of the gut wall is the serosa, or the adventitia, and we'll explain how to know the difference. Now here's a table covering each layer of the intestinal wall. And let's start with the top layer, the mucosa. The deepest layer of the mucosa, the epithelium, contains the gastric glands. Looking at this image, you can see the gastric glands labeled here. That's referring to these portions. And of course, there are glands throughout the epithelium. But these are the gastric pits, which house a lot of the glandular cells of the epithelium. This image demonstrates important cells associated with digestion and acid secretion in the stomach, and it can be found in the GI physiology chapter. I show you this now only to point out that these cells you see here, D cells, G cells, parietal cells, and chief cells, are all located within the epithelium. So let's go back to the table and say one more thing about the epithelium. If this layer is damaged, we consider this an erosion. However, if there is damage to all three layers of the mucosa, epithelium, lamina propria, muscularis mucosa, then this is considered an ulcer. If you think of peptic ulcer disease, the name itself tells you that all three layers have been damaged. Depicting this visually, an erosion only damages this layer, while an ulcer damages the entire mucosa, so all of this. And if we go to the far left over here, we can see that there are capillaries within this villi. So you can imagine that in an erosion, you actually can cause a little bit of bleeding via these capillaries. But in an ulcer, you can actually reach these bigger vessels, which can lead to bleeding as well, but it's more significant bleeding. If an ulcer leads to ongoing bleeding, the patient can actually develop iron deficiency anemia. To help keep erosions and ulcers straight in your mind, I suggest using this phrase: erode the epithelium and ulcerate the mucosa. The E in erode corresponds to the E in epithelium, and the U in ulcerate corresponds to the U in mucosa. EE and UU. Erode the epithelium and ulcerate the mucosa. Now focusing on the submucosa, we already discussed that it houses significant blood vessels. And if ulcers reach the submucosa, the patient can have anemia if the bleeding is chronic. What I want to draw your attention to now is the submucosal plexus. This plexus of ganglia regulates blood flow of the submucosal arteries and veins. This makes sense because this plexus is within the layer that the arteries and veins are located in, so it's logical that it would regulate blood flow. The next items to discuss are the Brunner's glands and the Peyer's patches. The Brunner's glands are located within the duodenum. Now this is important. So we know that the submucosa extends throughout the entire GI tract, but the Brunner's glands do not. These are isolated within the duodenum. And likewise for the Peyer's patches. Although the submucosa extends throughout the entire GI tract, the Peyer's patches do not. They are located in the ileum. Okay, focusing just on Brunner's glands now. If there is excess acid within the lumen of the GI tract, these Brunner's glands from the duodenum will undergo hyperplasia. And that's because Brunner's glands secrete bicarbonate. And since bicarbonate is alkaline, it can counteract the acidic material. And now for Peyer's patches. The Peyer's patches are lymphoid aggregates involved in the immune function of the body. Looking here, and we can see the Peyer's patches pointing to this lymphoid aggregate within the submucosa. With reference to Brunner's glands, when we're in the duodenum, we would expect to see Brunner's glands within the submucosa. Okay, now we're bouncing back to the Peyer's patches idea. If there's an infection, these lymphoid aggregates will enlarge, and this enlargement of Peyer's patches create a nidus for intussusception. Let's explain what this means. Notice on this image, we have the small intestine, and the ileum would be this last portion right here. And if the Peyer's patches, which are within the ileum, enlarge from an infection because they're lymphoid aggregates, then it can be pulled into the large intestine, this direction. And this will create an obstruction. So once again, infection leads to enlargement of the Peyer's patches, which can then get pulled into the large intestine. And this creates intussusception, which is an obstruction. Now we won't go into any more detail about this disease in this lecture, just have an idea of this process and how it's caused by Peyer's patches within the ileum. Now it's really important to remember that Brunner's glands are in the duodenum and Peyer's patches are within the ileum. However, keeping these ideas straight can be hard, so I have provided a memory hook to help you out. Pepe's brain dump. So P for Peyer's patch, and the I for ileum. So Pepe's, Peyer's patch, ileum. Moving on to the next part, Brunner's glands. Brain for Brunner's glands, and dump for duodenum. So Pepe's brain dump. And for this, I just like to think of a medical student named Pepe who is doing a lot of brainstorming, and she needs to do a brain dump. So Pepe's brain dump. Okay, now let's do a question to apply what you've learned so far. A 46-year-old man with a gastric ulcer is advised to undergo an upper endoscopy. The ulcer is identified and a biopsy is obtained. While examining the histological specimen, the pathologist identifies the cells that secrete hydrochloric acid. What layer of the gastrointestinal tract is the pathologist examining? Recall that hydrochloric acid is released from parietal cells. And what layer are the parietal cells located in? The epithelial layer. Not including the Brunner's glands, the epithelium houses most of the intestinal glands. And these intestinal glands include parietal cells. Now this is a histological image taken from a biopsy of the gastric epithelium, and you can see the parietal cells prominently here. They appear as little fried eggs with a yolk in the middle. Look at all these fried eggs scattered throughout this biopsy. These are all parietal cells. Now let's go back to the table. We are reminded that the gastric glands are located within the epithelium, the most superficial layer of the mucosa. Now let's do another question. A 12-year-old boy presents to the emergency department with excruciating abdominal pain. A CT scan is performed and reveals a distal segment of the small intestine within the most proximal portion of the colon. The mother states that her boy recently had several days of diarrhea and vomiting last week. If the illness the mother described was the cause of the findings on imaging, what layer of the gastrointestinal wall is likely responsible? Hopefully you noticed that this boy's ileum entered the colon, because a distal segment of the small intestine entered the most proximal portion of the colon. This is intussusception. Hopefully you also noticed that this child had an intestinal infection, as a mother stated with the diarrhea and vomiting. So how did the infection lead to intussusception? That's enlargement of the Peyer's patches. And within what layer are the Peyer's patches located? The submucosal layer. And that answers our question. Going back to the table, we are reminded that the submucosa houses the Peyer's patches within the ileum. And we know that they're in the ileum because of Pepe's brain dump. Peyer's patch, ileum. Now let's talk about the muscularis propria. This has an inner circular layer of muscle and an outer longitudinal layer. Sandwiched between these two layers is the myenteric plexus, which is responsible for peristalsis. On this image, you can see the circular layer right here. This is the inner layer. You can also see the longitudinal layer right here, which is the outer layer. And once again, between them is the myenteric plexus. Now this image demonstrates a cross-sectional cut of the gut wall, and it can be found in your GI anatomy text in section 4. Right now, I want to draw your attention only to the muscularis portion. We have the inner circular layer, closest to the lumen, and the outer longitudinal layer. Notice how the fibers within the inner circular muscle layer run in a circumferential pattern, whereas the longitudinal muscle layer has muscle fibers that run in a longitudinal direction, like this. And again, sandwiched between the two, we have the myenteric plexus. This is a histological image of the muscularis propria, and we have the outer longitudinal layer here, the inner circular layer, and between them, the myenteric plexus. And if you zoom in, this is what the myenteric plexus will look like. Going back to the table, we can see that the myenteric plexus regulates peristalsis. It makes sense that it would control peristalsis. After all, it's sandwiched between the inner circular layer and the outer longitudinal layer, which layers are responsible for movement of food throughout the GI tract. So the plexus between these two muscular layers would logically contribute to peristalsis, which brings us to our pathological tie-in. Any disruption of this layer can lead to achalasia or Hirschsprung's disease. This is a barium swallow showing achalasia, and this is an esophagus. Down at the bottom is the lower esophageal sphincter, which I will write as LES. Notice this narrowing. This is abnormal, obviously. This occurs because the myenteric plexus failed to perform proper peristalsis. Specifically, it fails to allow the sphincter to relax, so pressure will build up in the esophagus. Now this image demonstrates Hirschsprung's disease, and this affects the most distal portion of the digestive tract. Now this image actually demonstrates normal anatomy, so don't get wrapped up in how this appears, just know that we're referring to this distal area. And the intestinal wall down here should have a fully functional myenteric plexus to allow proper movement of food and excretion of food. Without the plexus, peristalsis will fall and stool cannot pass. So just like in achalasia, there will be constriction here and pressure will build up. And all of this pressure will lead to many problems. Again, it's very important to remember that achalasia and Hirschsprung's disease result to damage to the myenteric plexus, which is in the middle of the muscularis propria. And since it is so important to remember all these connections, I've provided a memory hook. My muscles ache, her muscles ache, our muscles ache. My for myenteric, muscles for muscularis propria, and ache for achalasia, and her for Hirschsprung's disease, and lastly our for Auerbach's plexus, which is another name for myenteric plexus. So again, my muscles ache, her muscles ache, and our muscles ache. I just like to picture a guy and his girlfriend walking out of a gym after a long, tiring workout. And he's just saying to himself, my muscles ache, her muscles ache, our muscles ache. And if you can remember that, you can connect all these ideas. So now let's do a question to apply what you've learned so far. A 2-week-old infant fails to have any bowel movements. The pediatrician suspects a deficiency in functional tissue responsible for peristalsis. In the suspected condition, what tissue is defective or absent? What layer of the intestinal wall normally houses this tissue? Now hopefully you notice this neonate has Hirschsprung's disease, as the pediatrician is focused on the tissue that is responsible for peristalsis. And what tissue is responsible for this? It's the myenteric plexus. And what layer of the intestinal wall normally houses this tissue? Well, it's the muscularis propria. And just remember the phrase, my muscles ache, her muscles ache, our muscles ache. We're dealing with Hirschsprung's disease, which results from dysfunctional myenteric plexus, also called the Auerbach's plexus, and this is sandwiched in the middle of the muscularis propria. And again, we can see the myenteric plexus right through here, sandwiched between the inner circular layer and the outer longitudinal layer. Now let's go to the deepest layer, the serosa, or the adventitia. Like I said in this other image, this is the serosa or adventitia. So why do I say or? This is because whether or not it's serosa or adventitia depends on the part of the intestinal tract we are dealing with. Some parts of the intestinal tract are retroperitoneal, while some are intraperitoneal. So this line right here and backwards indicates retroperitoneal structures, and retroperitoneal structures would be covered with adventitia, whereas this line and forward would be intraperitoneal. Now going to this image, we see the stomach right here. And since it's anterior to this retroperitoneal line, do you think it would have serosa or adventitia? Well, since it's intraperitoneal, it would have serosa. And the serosa allows for lubrication of all these intraperitoneal organs that are free-floating in the intraperitoneum. So it needs serosa, whereas everything back here doesn't need all that lubrication. All it needs is adventitia. The last item that we need to discuss on this table is the Taenia coli. This is made of 3 longitudinal ribbons that follow along the colon. And the Taenia coli can actually be palpated to identify the large intestine. So if you're looking at the colon, you can see the Taenia coli. Here's one ribbon you can see. Here's another ribbon you can see. And recall there are 3 of them. And it starts at the appendix right here, and it travels all along the large intestine. To reiterate, it's palpable. So if you're in a cadaver or in a surgery and you're palpating around the intestines and you feel the Taenia coli, you know you're touching the large intestine. And that concludes this section.